Dr. Penix's time. He's done. We'll go back and do the beginning.
Okay. I don't need to say anything like good morning.
Should probably say good
I
morning.
would say, okay. Good morning, everyone. Welcome to this December meeting of the Mental Health San Francisco Implementation Working Group. I now call the meeting to order. Please note that this meeting is being recorded on WebEx. The recording will be available on the Mental Health SF website. Should I do the land acknowledgement real quick? And then we'll skip that and just do that.
Yeah,
And then-
sure.
and then-
And Kaylee, can you start the recording, please?
Oh yeah, Kaylee, start recording meeting. Actually, fine. Okay, is land acknowledgement. The San Francisco Department of Public Health staff acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community and by affirming their sovereign rights as First Peoples. Thank you. We are moving to discussion item number 2, the Mental Health SF Directors and Department Update. This is our second time with our new process of doing short mental health SF updates with Q&A. Okay.
I just want to make sure. Kaylee, can you verify that we're recording? I don't see the little thing that says. recording in progress. So it's not-
Yes, we are.
We are? Okay, thank you.
You want me to
No
text you?
worries.
Okay.
Is this on the slide? It's not on the slide. Sorry, I'm just fine. Hi, everyone. Good morning. I just found a question that I wanted to ask Valerie. Sorry for the whispering. Good morning. Thank you for putting me up on the agenda. Acting Chair Salinas, is that the official title? I can be here till 10. I think I'll have time for a conversation, most likely. We have a couple of slides. So if we, whoever has, I guess Kaylee.
Yeah.
Kaylee, could you advance the slide, please? Thanks. Next slide. So I have some general updates, what's happening in the city, and then I have, of course, some mental health SF specific updates. Next slide. So first, I just want to, there's a number of upcoming hearings coming up that I want to make this group aware of. Sometime in January, we will be having a hearing on the status of our residential care and treatment system of care, and specifically our expansion. You can see the text on your slide. I'll say that an important thing that we're doing is really attempting to not only inventorying the expansion, which this group has been, hearing about quite a bit in quite a lot of detail, inventorying our larger system of care, and then trying to address some historic issues in bed closures or changes that predate me, actually, and really trying to understand some of the questions that have been coming up about where we need to go in terms of what we think is sufficient residential care and treatment capacity. The other upcoming hearing will be on the street cleanings audit that the BLA produced a report about.
We shared it.
And was shared with the group. That report highlights, I would say, some of the complexity and how the city has been implementing and coordinating street teams. I'll note for this group a number of things in that report that were kind of cited as, I would say, opportunities for improvement actually have happened already. And so during the hearing, I think that will be discussed. We, DPH, are not the main presenter. The main presenters will be Department of Emergency Management, who has been assigned the role of coordinating all of the street-based teams, and San Francisco Fire Department. And we will we'll let folks know when we have an updated date. Okay. Next slide. Next slide. Thank you. So first, I want to go domain by domain. As you can see on that slide, the street crisis response teams, the monthly dashboard continued to be posted on the sf.gov website. So I just want to make sure people are aware of that. I think that I know Chief Peng was here last month and spoke with all of you. And I know that the group had came with a number of questions specifically about follow-up care after a street team encounter. We are having the Office of Coordinated Care come to IWG in February and want to sort of engage in that conversation, get so you can hear more detail about how that's going, get feedback, and we're looking forward to that conversation. Next slide. Oh, I forgot to say just at the top, just our plan is for January, I think sort of in line with some of the things we've been talking about, is we're going to have all the domain leads here in January and try to test out doing brief updates from all the domains, and we'll see how that goes with all of you. So I'm here in their stead a little bit representing, and you can imagine I don't have all the details, but I have a fair number. So the first thing, so I think just to reiterate, as part of OCC, we created the Best Neighborhoods team, which is the follow-up team dedicated to neighborhood-based work and working very closely with SCRT to do follow-ups. I think the first terrific news is that Best Neighborhoods is getting an award from the San Francisco General Hospital Foundation Community Impact Award. I think that's, I mean, we're really happy about it. The team has really worked their heart out, and particularly, you know, with the transition from the SCIRT team to the Best Neighborhood team, it's been really sort of full on transitional time, and the team is, I think in our view, functioning extremely well. So that team is building out 6-day-a-week service, 7-day-a-week service. Right now, they're operational 6 days a week from 8 a.m. to 6 p.m. The ultimate goal will be 7 days a week as we complete hiring. Other news from the Office of Coordinated Care, and this is sort of in response in part to some of the questions that came up last time, as I understand. This is also in the SCRT dashboard, so you can see on the slides in front of you, I'm just reading the numbers. In October of 2023, the fire department sent a total of 230 clients to the Office of Coordinated Care. 195 remained with the Office of Coordinated Care with their case management to assess their follow-up needs and get them connected with ongoing care. 29 were referred to the Department of Homelessness and Supportive Housing because their primary need/interest was in some sort of housing support. And then after assessment, 6 really had no specific follow-up needed. Of the follow-up assessments, so of the 195, 20, a little more than a quarter were connected or reconnected to providers. 17% were connected to a new behavioral health care service or follow-up team. About half were provided care coordination services, either with potentially the goal of resolving it with care coordination or continuing to work to establish the ongoing care. And then 5 or 3% were not able to, not insufficient information was had by us to either find the person or assess the person. So that's really something we've been working on, is to get enough information to really do both an assessment and follow-up.
Are you able to explain the distinction between the first, they're not numbered, so the first bullet and the second bullet, that is the connected to existing providers versus connected to new behavioral health care? I'm not sure I quite understand that distinction.
I'm gonna get back to you.
Okay.
As I was reading that, realized a follow-up team is clear to me, meaning it's not intended to be the kind of forever team. It's really a team that's doing more than likely kind of street-based care linkage, care management, some direct care where needed, but the goal is to transition to some sort of continuity or longitudinal care. That first bullet I'll clarify that, because I'm not sure the difference either. My apologies, I missed that.
Thank you.
No dumb question.
What do you use care coordination services if they don't involve connection to a provider or follow-up team?
Sometimes it's things like, for example, they could go to care, but they need an ID. So we're going to help you with the logistics, but then they're sort of off and running. Or, oh, gee, I need information to get a medical record from point A to point B. And so that's all they need. So they're maybe placed in care. And we can get, when the OCC comes back in February, we'll get some more specific examples.
So it's like brief case management. service.
Brief case management services.
It's 4.5, and they're just trying to figure out.
Yeah. I think one of the learnings there is some amount of people who are being seen by the street crisis response team. Not everybody needs longitudinal stuff. And I think we are learning that as much as, and trying to give the right level of intervention to the sort of heterogeneity of people we encounter. Partly in order to focus on the highest need people who really, really need to be sort of situated in the right level of behavioral health care.
You got to see it.
I have further questions, but I think I'll wait till January.
Okay.
We're going to ask questions.
I wonder, could I ask one quick question?
Yes.
What's the definition, Dr. Cunnins, of connected? Does that include they were actually admitted into service with another provider, or that an acknowledgement was made, that a referral was made, and whether or not there's a wait list or they don't get into that other service?
It's till getting into receiving a service. So
Okay,
it's
so
not
being
just
engaged in it. Yeah, okay.
So as you know, engaged is also a complicated thing to measure, right? But
Right.
it is, so the teams are intending to make sure people, are in the care and are going back to the care, not just lost from the care. So it is definitely a higher level of aiming for a higher level of connection than here's the number to call, or even here's the number, I'll call the number and you have an appointment. So it's really trying to do much more support than that.
If there is an acknowledgement of the referral, but there's a time lag for an intake, or there's a wait list, how does that play into connected? Because we do know we have a problem with available slots in certain systems, and I know our crisis residential programs always have trouble until coordinated care is getting connected literally to case management. So how does that element play into it?
The goal is that the OCC stays with the person until they are situated. So this is really, I totally agree with you, right? Because, a 3-month appointment is not connected to care. And so the goal is to stay with the person until that handoff happens.
Great. Thank you.
Next slide. Let me just say a few more words about OCC before I go on to new beds and facilities. We are really overall trying to move to 7-day-a-week services within the Office of Coordinated Care. So right now, what we've got going at 7 days a week is our behavioral health access line. That is not new. Our behavioral health access center, which, as you know, opened on Saturdays and Sundays in the fall. Best Neighborhoods, which I just mentioned, is now 6 days a week. Our triage team, which is kind of the assessment team, is operating 6 days a week. And the care management team is currently operating 5 days a week with a goal to go to 6. And then ultimately, we want to bring all those services to 7 days a week. So we're not there yet, but that's where we're aiming for. Okay. New beds and facilities. You're going to hear more about this, about Summer Rise later today, I believe, from Dr. Pading. I wanted to update you on the crisis stabilization unit, which I know you all heard a lot about, and perhaps there's been silence as the real estate and planned building work has been being planned. We are expecting there to begin a community input process in January. We will, I don't know whether it's before or after the next meeting. I don't know that we have dates
I don't think we have
scheduled.
a date for it yet.
So I want to just make sure you all are aware it's happening. We have to make sure to get you, if we're having any community meetings, I want to make sure you all know about those. I feel like it is possible, I don't know, that we will have community concern and or opposition. And I think having this group feel comfortable, you know, as you speak to friends, colleagues, neighborhoods, be part of our saying that this is a needed service and important to the fabric of our city. So I hope, I want to keep you all in that loop and feeling positive both about what we're saying, but also helping us be emissaries, I
Can I ask you
think.
a question about that?
Yeah,
So are you aware of opposition?
no.
Okay.
I'm playing defense.
Okay, so I'm not going to ask the follow-up. Okay.
I mean, I think I'm extrapolating for some of the work that happened in community around Summer Rise.
It sounds like, is it more that you think whether you call it opposition or concern with relocation versus the students and stuff?
Some, you know, people, community members, so mental illness and substance use are stigmatized. Community members, you know, sometimes raise their hands to say, we don't want this here.
So that's a location.
That's a location issue. I think sometimes NIMBY.
Yep.
I think, I'm trying to be polite. I think sometimes people have misunderstanding about what the service is. I think it's on us as government and on us as whoever the potential provider is, right? That's going to be RFP'd. to really commit to being good neighbors and being participants in the community. I think issues are, I'd like to think, always resolvable. I think, and you know, David, maybe David Payton can address this later. I think we've actually are in a good place with Soma Rise because for many reasons, our provider has been really trying to be a good neighbor and responsive to concerns. We've held a lot of community meetings. We want to do this in an open way, be responsive to feedback, be good partners, and express and work against stigma.
Be open to doing meetings in District 10, in our district.
The district,
in the-
yes, we are intending to. What, and what, I don't, six.
I could,
Someone has it, but yes, and are you,
I could be a liaison to certain organizations that,
fantastic,
That would be great.
that would be great. Thank you.
I also want to be brief, but some of this is just age old. It's just age old discussions,
Yes,
you know, that are outdated.
I agree.
I can remember I went to all of the District 10 meetings, no, all of the city budget meetings. And so, you know, the conversation is different in the Marina District. It was interesting. They were talking about raising money for bigger businesses and things, but they were mad and almost protesting the group home.
Yeah.
Oh, my God.
Yes, yes.
Dr. Pading, Dr. Pading, not yet. I have no question that Dr. Pading might be better to answer, but having gone through about 20 of these in my time, the key issue for me is, does the site require a use permit in order to be developed for this purpose? In other words, does it go through a planning commission meeting and then a potential board of supervisors appeal? So because the relationship with the community opposition also is in direct proportion to where there needs to be approvals for the site. So does it require a use permit for this particular site and purpose?
You know, I don't know. We'll find out.
We can ask, David will be here.
And David may know, the good Dr. Pading may know. But I do not. But yes, exactly. Last update, which I want to make you all aware of, we are pursuing expanding our dual diagnosis capacity in a number of ways. I just wanted to let the group know we did enter into contract for 7 dual diagnosis beds out of county because we could do that. Quick is a sort of overstatement, but we were able to get that done now. That is not necessarily a forever thing and not our preferred approach. We are working concomitantly to add capacity or continuing to work to add capacity in county.
So those are residential treatment beds.
Those are residential treatment beds intended for people with both moderate to severe, both mental illness and substance use disorder.
And they will be referred to be from a hospital or?
They are going to be, so I don't, like, they're new, they're brand new. And I think, for example, our ICM programs might be a good, referral source. It's not exclusively intended to be from the hospital. It is being, it's not going to be by direct referral, it'll come through our treatment access program. So is that what you were asking?
So it'll be through TAP, not through RSOC.
You know what, I don't want to speak out of turn, either RSOC or TAP. So we'll get back to you on that.
Which county are you in?
San Mateo.
San Mateo,
Okay, so not too far.
not far. not too
They
far.
want the Alameda facility that is apparently closing.
Okay, next slide. So analytics and evaluation, I feel like, I'll just kind of acknowledge that this has been, data has been slow moving. I think, I guess my own learning is that our many systems as well as staffing challenges have really, slowed our process here. You have seen some of these data. We have done significant revisions as we validate data, clean data. We are just about ready, and we'll share with this group before it goes public, specific dashboards and data about 5150 follow-up that are 5150s coming out of Zuckerberg. So right now we have set up, I think as you've heard, a standard data stream from from our hospital essentially. And so we're able to look and see the extent to which we have connected people after an involuntary psychiatric hold with ongoing behavioral health care or primary care, with the nuance that Member Fields was just asking about. We have revised and looked further at our intensive case management wait times. You've seen those data before. And we are working to finalize mental health and substance use residential wait times. So we are in the sort of final stages of validating those metrics, and we will come back to you and share where we're at with those. Finally, not finally, just an update on our Office of Overdose Prevention. You can see that we are continuing to aggressively conduct overdose education and naloxone distribution citywide. We are very much targeting areas of the city and populations at particularly high risk for overdose. And we are doing this by working with and in strengthening relationships with community-based organizations, particularly Black-led and Black-serving organizations, faith-based organizations. We are also working with a variety of schools, other city agencies, and then I want to, and housing, both supportive housing and other SROs. We have also been amplifying our work with the Entertainment Commission, trying to push into nightlife venues to get to additional populations who could be at risk of overdose. Next slide. I think that's it. Last thing I want to cover, I'm okay for time. I just want to acknowledge the members again, our membership challenges with Member Hammer's upcoming retirement. Which is very sad. And great for Dr. Hammer. We know that it may be even more challenging to meet quorum, and I'm working closely with Valerie. So we're working with the board to elevate our concerns, to try to get things moving. I think everyone knows, Valerie's been reviewing applications, working with the board clerk about board appointed seats where we can. So I just want to tell you that we'll work on it again.
Does that mean the mayor's office is basically not connected on this?
And we are also connected. No, we are also working with the mayor's office and connecting there. So, I think this does not reflect. I mean, this is a high priority, as you know, a high priority issue for the mayor, for the board, and is we're getting it unstuck. I just wanted to say that to all of you. So that's all I got.
That question. Has the Where is the department in terms of collecting the data required by the state on 5150s?
Oh, that's a great question.
I'm just looking at slides on it.
So we welcome that legislation. Because it will allow us to know about the 5150. So for everyone's awareness, there's a new state requirement that in theory, I believe was enacted a while ago.
Whether we're
Steve has his
Okay.
notes.
There were data collection passed last year, which is number of persons in designated and approved facilities, and persons transferred, persons for whom temporary conservatorships were established, and so forth. And then next year,
So this coming year,
coming year, I think in May, to collect the number of persons admitted or detained, including 22-hour, 72-hour evaluations, 14-day and 30-day periods of treatment, and the 180-day poster that are broken down by danger to self, danger to
Yeah.
others, grave disability due to mental health, grave disability due to severe substance abuse, and grave disability for dual diagnosis.
Yeah.
That's not till next year.
so that is coming up in May. So we have been working with hospitals, and we ourselves are setting up ways to receive the data. So that's in progress. And what I would like us to end up with is, just as we are doing 5150 follow-up tracking, so we know who folks are.
Yeah.
I am hoping we will get to the place we are doing it citywide.
Yeah.
Now, and that's because that's the only way that we're going to improve. We also, as I think everyone knows, 5150 is, a thing we want to avoid. It is a difficult, very difficult moment for the person. It means that systems have not succeeded. I mean, I want to just be clear, this is an adverse event, I would say, like as we say in medicine. And it is a thing that we need to act on to make sure to really focus on those folks who are at great risk. First of all, of the subsequent involuntary hold, and really it's evidence that we as a system have not succeeded in preventing the crisis. So taking those as kind of sentinel events of having to do better, really wanting to work with the person on a voluntary basis to get them into the best possible situation. So that's how, so I'm looking at it, we are looking at it with a high priority and welcome approach.
Citywide has collected our own 50/50 data. It's,
Do we know about that?
I don't know.
No, we'll find out.
No, but we have been
That's great.
collecting it for
Collecting, both how many of your clients are 5150 or also follow up after 51?
We collect, every time we have a Qualtrics, we do every single time staff 5150 someone, what we were 5150 them for and the outcome. So we have like quantitative and
It was like a required.
because
Or just a.
because we were frustrated with how those were going. And so we decided we were going to start collecting our own data because we were having such difficulties, mostly because it mostly came about once police policies changed.
Yeah.
So that we were having lots and lots of difficulties, 5115 people that needed to be 5150. And so we just started collecting quantitative and qualitative data about.
That would be,
We're doing it at least 2 years now,
That's
maybe
great.
3.
that's great. That'd be very helpful. Yeah, that'd be great to know about.
So I don't know.
It's some combination of the Office of Coordinated, it's mostly in the Office of Coordinated Care under Heather Weisbrod. I'll touch base with them.
And Heather, she can, Allison Livingston has mostly been,
Right.
and Charlie Berman have been mostly
on it.
working on
That's
it.
great.
Um,
And it would be good to learn, from your learning. It's like what you've learned from it and how we can do better.
What,
Yeah.
what kind of Black organizations are you working with?
I have to get you the list. I know some offhand, but I don't, we have been, let me get you, we'll send out the list of who we've been working with. And happy for more like ideas.
Okay. Yeah.
We have, in our Office of Overdose Prevention, a person, who has been dedicated specifically to working with, Black African Americans in the city. Her name is Adrienne Jackson. She's been really wonderful. I think we've heard wonderful things about as she's, establishing relationships. And I would say sort of the entry point is overdose prevention, but really it ends up being, opening doors to obviously what else community members would like and need. And we are trying, to use that as feedback and support for as we continue to work to, to save lives from overdose.
Are you working with any shelters?
We are working with shelters sort of in a different line of work. We are doing that in a number of different ways through whole person integrated care, which sits actually under Dr. Hammer in ambulatory care. We have a whole shelter health program. We also within behavioral health are growing a shelter health team who will be doing specific work from the behavioral health point of view in shelters. But the current shelter health team does not only overdose prevention, but also both does treatment, mostly buprenorphine treatment, and also makes referrals to SUD treatment. But happy also for other recommendations, like if you're aware of shelters that you feel like could use more or different, let us know. And
We have a work order with HSH so that we get nurses into the shelters and so they're on site there. And then obviously and then like Dr. Coogan says, I said your name wrong. Dr. Coogan said, growing the behavioral health presence there as well.
All right, I wanted to make sure that Steve Fields has his hand up before we move to public
I'm
comment.
sorry.
But I appreciate it. Thank you. Just one quick question about the anticipated hearing on residential treatment system and its status and future that you alluded to that's coming in January. I know one of the things when we were working on the Office of Coordinated Care, there was a lot of input solicited from the existing case management systems we have and have had in the city. Is there going to be an outreach to providers like PRC Baker, Progress Foundation, to get ideas from those providers about where the flaws are and where the gaps are and where the strengths are in the existing residential treatment system?
Steve, that's super, thank you for raising that. So I will say that for this hearing, I think, I'll just say the context for a second. I think you probably know this. Supervisor Mandelman called this hearing. Supervisor Mandelman has a very specific interest in a particular aspect of that level of care. And that is specifically highest end locked subacute treatment. And I'll say also secondarily state psychiatric, capacity, both of which I think are genuine challenges. I feel like, Steve, Member Fields, what you are raising is, and I know you and I and you in this group have talked a lot about this, is creating much more robust recovery oriented, not only residential care, but just since you're raising that, as well as maybe some other, suggestions. So I feel like in the hearing is not the way we're going to surface, unless, I'll just again sort of ask for help, I guess. Sort of as this group or you in your provider capacity, sort of stressing we need a range of residential care. It's not just about locked beds, because I know that hearing is going to end up, I suspect that hearing will be a lot about locked services. I think separately from the hearing and sort of separately from the hearing, we're, as you know, contracted with Mozamtech to revise and update a quote unquote bed analysis. We are working on sort of, I don't know, iterating on the model to see if it feels like it makes sense with what we know in the city. I think what I would love to do, Steve, is, and whoever, either from this group or beyond, is to really have a conversation about those findings. And I think really hear whether they make sense and what's missing and how we can quantify, or what I am guessing you're also kind of suggesting is how we can change qualitatively, perhaps in some case, about what is needed or articulate what is needed. Does that make sense to you?
That makes sense to me. Any conversations that draw on the experience of
Yeah.
existing providers, the politics of it, the way the pandemic affected the current way in which these services operate in the various organizations, and looking at historically where we were just before the pandemic in terms of some of our goals of avoiding emergency rooms and hospitalization. I mean,
Yeah.
I don't think we've looked enough at that data, then applied it to the system we had at the time, where we were heading and where we probably need to head going forward with the new challenges. And I think there's a lot of rich information out there that the department would benefit from, whether it comes, and I think I agree with you, coming off of some document or some analysis and reacting to it is really helpful, because I mean, there's a lot of rich experience in residential treatment in San Francisco, and it hasn't been drawn on yet for all kinds of reasons. So I look forward to that. Any conversation that enlightens us and leads us in a direction that makes sense, if we have a commitment to recovery and community-based services whenever possible, is going to be helpful. Because I've had discussions with Supervisor Mandelman's office, and I know he understands the broader issue. I just think that the reaction that counties have so quickly to go to locked beds because they haven't yet figured out how to develop a system that could avoid it is something we just don't want to do in San Francisco until we have to. So I look forward to that. I think it'd be a rich conversation going forward.
And so we'll, I would really welcome that. And I see Dr. Pading, who we've now mentioned several times during this meeting, is also on, has joined and is hearing this conversation. So thanks, Member Fields, for your comments.
Last, I just want to make sure, Sarah, do you have, just that you have space if you have any questions to ask it before we move to public comment?
I'm okay, thank you.
Okay. All right, Diana, you want to move us to public comment?
Yes. And then I'm just going to remind us too that after public comment, we first need to go back to do the attendance and the approving of the minutes, and then we will go to the summarize part. So members of the public who wish to provide public comment on agenda item 2, which is the MHSF director's update, are invited to participate in 3 ways. First, we will call it in person, and there are no members of the public here in person. So then we'll call on people who are joining online, either through video or by phone. You can raise your hand if you're joining by video, If you are joining by phone, you could press pound, then pound again, and then *3 to line up to speak. The system prompt will indicate you have raised your hand. Please wait until the system indicates you have been unmuted, and then you may begin your comment. All members of the public who comment will have 2 minutes, and I'll give you a 30-second warning when your time is nearing completion. So if you'd like to make a public comment, please raise your hand at this point. And Kaylee and Jen and those of you who are online, if you could let us know if you see any hands raised. Right now, I do not see any hands raised. Kaylee and Jen, do you see any hands raised?
Nope.
I don't see any either.
Okay. And I think we can move to, we can close public comment. Oh,
Can I make just one, I just forgot to mention one thing and then I'm gonna just head out. Just to make people aware, there's gonna be monthly overdose numbers will likely be released later today. I don't know what they are yet. And there is going to be a press conference held by DPH, sort of, talking about the numbers and so forth. So you'll likely see that in the paper tomorrow. So just wanted to alert people. I'm gonna head out. Good to see everyone. To my next gig. Good to see everyone. Thanks very much for feedback, everyone. Happy holiday. Happy New Year. Enjoy.
slide 3.
Oh, that was about to sleeping. Roll call, but, okay. So we have to go back to roll call, right?
Yes.
But she just left, so,
But she said she's here.
It's here.
Yes, she's not here.
okay.
So
So roll call will now be taken to establish quorum. Upon your name being called, please appear or present.
okay, Member Fields. Member
Here.
Fields. Hey,
Here.
Member Gonzalez. Here. Member Hammer said here earlier. Member Lipton.
Here.
Member McQuegan, we know is absent. Member Patterson.
Life is a gift, that's why they call it the present.
Member Salinas.
Present.
Member Shore.
Here.
Member Wong.
Here.
Okay, we have 1, 2, 3, 4, 5, 6, 7, 8 out of 9. So we have a quorum. And now we need to vote to excuse the absent member, which is Member McGuigan, who had emailed us ahead of time saying that he was not able to make it today.
So moved.
I think I need to read this. We must vote to excuse absent members. Any member who misses 3 regular meetings within 12 months without the express approval of the IWG will be deemed to have resigned from the IWG 10 days after the 3rd unapproved absence. So Member McGuigan submitted a request for excused absence. Is there any discussion, Chair, before we move to a vote?
No, does anybody wish to discuss? We do not wish to discuss. Please proceed with the vote.
He's a cool guy.
So I will now call roll and ask each member to vote yes or no to excuse Member McGuigan. So yes, a yes vote means you vote to excuse him. A no vote means you do not vote to excuse him. So Member Fields,
Yes.
Member Gonzalez,
Yes.
Member Hammer is not here right now. Member Lipton,
Yes.
Member Patterson,
Yes.
Member Salinas,
Yes.
Member Shore,
Yes,
Member Wong. Okay, so we have 7 yes votes and 0 no votes, so that's a majority to excuse Member McGuigan. So I think we're on to slide number 5 now.
Okay, today we have the following goals for our meeting. Receive updates on the behavioral health services and mental health of staff. Receive an update on the Sunrise pilot project. Receive an update on the DPH annual implementation report. Receive an update on IWG community engagement. receive an update on IWG membership and governance, plan for upcoming IWG meetings. Take it away, Jen.
Jen? If you're talking, we can't hear you.
All right. I think we can keep.
Yeah, I think we can keep going because she was just gonna say,
Yeah.
Here's everybody, yeah.
Great. We will have the following presenters today. Dr. Coonens will provide her usual department updates, which has already been done. To present on Summarize, we will be joined by Dr. David Pading, the co-lead for SFDPH New Beds and Facilities, Diana Castillo, the Director of Crisis Services at HR 360, and Haley Musso, a Senior Research Consultant from Harder and Company Community Research. And Kelly will be presenting on the DPH implementation report.
Valerie.
Valerie. Okay, we will now move on to discussion item number 1, approval of the November 2023 IWG minutes. These minutes are posted on the IWG website. Are there any changes to the minutes as posted on the IWG website? Are there any substantial edits, changes? Okay, so now we will pass on to Diana for public comment.
okay, so this is public comment on discussion item 1, which is the November meeting minutes. So again, we'll do it in 3 ways, calling up people who are here in person, and there is no one here in person. And if you're joining online, either by WebEx or by phone, you can raise your hand. To raise your hand, if you're calling in, please press pound, then pound again, and then *3 to line up to speak. You will have 2 minutes to speak, and we'll give you a 30-second warning. If you would like to comment on the meeting minutes, please raise your hand now. I do not see any hands raised. Haley or Jen, do you see any raised hands?
Nope, I don't.
Thank you. There is no more public comment. So public comment on the meeting minutes is now closed, and I will pass it back to the chair to vote on the meeting minutes.
We will now vote to approve the November 2023 meeting minutes. Do I have a motion to approve the minutes? Motion. Thank you. Is there a second?
I second.
Thank you. I will now call roll call and ask each member to vote yes or no to approve the November 2023 meeting minutes. Member Fields,
Yes.
Member Gonzalez,
Yes.
Member Hammer,
Yes.
Member Lipton,
Yes.
Member Patterson,
Yes.
Member Salinas, yes. Member Short,
Yes.
Member Wong.
Yes.
We have 8 yeses and 0 nos. We have a majority vote to approve the November 2023 meeting minutes. Oh, that was Diana.
You did an excellent job.
I'm like, I just want to roll through.
Yeah.
Now we are moving to discussion.
Consolidated power already.
Hold on. Now we are in discussion item 3, slide 19. So for this presentation, we are joined by David Pading, the co-lead for SFDPH New Beds and Facilities, Anna Castillo, the Director of Crisis Services at HR 360, and Haley Musso, a Senior Research Consultant from Harder and Company Community Research. I will now pass to David. Dr. Pading, thank you for coming.
Good morning, everyone. Thank you very much for inviting me and our team today. Can you hear me?
We haven't seen it.
Yes, okay. We're going to talk about the year 1 pilot evaluation for Summarize. And I'm David Pading. I'm our new beds and facilities co-lead. And I'm here with our Health Right 360 partner, the Director of Crisis Services, Diana Castillo, and Haley Musso, who is our Senior Research Consultant from Harder and Company. Before starting, I want to just apologize for not being there in person. First, I had no idea where you were today. I Googled the address and it put me in San Mateo somewhere. I guess there's multiple Valencia streets. And then secondly, we didn't want to give you a kind of fragmented presentation, and we have a lot of slides, so we thought it's easier to stay on one screen rather than a hybrid. Next slide, please. Now, I believe most of you have been around when, or were around, I think we're still with the original team, when we started Summarize. Summarize began in 2019. It is a drug sobering center. Drug sobering center were a top priority of the San Francisco Department of Public Health's methamphetamine task force and mandated by the MHSF legislation in November 2019. In June 2022, that was last year, Summarize opened at 1076 Howard Street in partnership with Health Right 360. It's funded by Prop C and then supervised by you all as part of the IWG. Summarize, it's designed to serve the mental health San Francisco population, which, as you know, is people experiencing homelessness, those with serious mental illnesses, and with substance use conditions. Next slide, please. Summarize provides a safe, welcoming space for people to rest and stabilize, and then connect to care and services. The approach it offers is a patient-centered or person-centered approach that includes dignity services and radical hospitality. Radical hospitality is a phrase we adopted from Paul Harkin in the community, who many of you know. And it basically, as I understand, have come to learn and appreciate, means to say yes rather than no for people coming in and seeking services. So located in the South of Market or Soma district area, Summarize was intended to serve clients in the Soma and Tenderloin neighborhoods. It's open 24/7 for both walk-ins and drop-offs. It has 20 beds. And then on the right here, you can see the inside view without clients due to privacy of Summarize. I want to thank the IWG members who came to visit the site and the many questions that you had asked. We tried to incorporate them into our presentation. Next slide, please. The goal of Summarize was very simple. It was threefold. One, we wanted to have or develop a safe, welcoming place for people to come down from drugs. We wanted to serve people in crisis who are using drugs to prevent having a crisis on the street. And we felt it's better to be indoors and withdrawing or in drug-related crisis rather than on the street and outdoors where things can happen. And we wanted people to get linked to services. And the tools we used were, again, dignity services. This was offering food, showers, rest, health screening, peer support, referrals, and outreach. Next slide, please. The path to getting to Summarize was longer than you may have initially thought. In November 2019, we got the mandate from MHSF for Drug Sobering Center and began immediately to look for a site with planned construction. We found one in the Tenderloin at a neighborhood on Turk Street in a parking lot that we were going to convert into an outdoor sobering space. Unfortunately, we had gotten as far as beginning to permit, to develop architectural site plans and purchase equipment. But in the middle of that, COVID came. And by about June 2021, we realized with the abandonment of all construction in the city that we were not going to be able to get a Summarize services put at that site. So we quickly regrouped. I guess this was in the middle of 2022. And by the beginning of 2021, identified a second site at Howard Street, the 1076 Howard Street, which is the current site. And this required extensive remodel and construction. Health Right then joined us for the program design, and we began our official reboot at the second site. By June 2022, we finished construction of that site, bought all our supplies. We actually had supply problems related to COVID. We couldn't get an HVAC system offshore that sat in a boat for like 3 or 4 months, and it was one of the most significant delays that we had. We trained up staff, developed protocols, and most importantly, we built our Epic network, which then went live in October 22. So we opened June 29th, 2022, got Epic on board in October. And what you're seeing now is our year one evaluation. And in year one, very happy to say we became a CalAIM Community Support Services. And now over the third of our costs are able to be reimbursed by Medi-Cal CalAIM. And we continue to work to find the groove of SomaRise. In February of this year, we asked Harder and Company to provide the year one evaluation of our drug sobering center, SomaRise. And they were asked to answer 3 questions. One, is it an accessible program with minimal barriers to entrance and participation, namely low threshold or low barrier? Does it serve people experiencing drug crisis, especially those referred by the crisis street teams? We really wanted this to be a coherent part of MHSF. Does it link clients to treatment or other community services? And has it impacted the community either positively or negatively? Next slide, please. The evaluation was performed in 3 parts. It was a participatory framework and involved sense-making sessions. That meant after every part of the evaluation, the information was brought back to the team. And while the evaluation started in February and took about 4 or 5 months, this was actually, we used this as a quality improvement project. So even during the evaluation, we continued to make changes and improvements. The first phase was more quantitative, looking at 6 months of data that we were to have at that time in Epic, October through March. We, in the second phase, did qualitative interviews of participants and of staff and key stakeholders. And then the third part, we brought it all together, figured out what we need to improve next, did some media scans, and then here we are with you presenting our results. Next slide, please. So let me begin with who is served by SomaRise. On the left-hand side here, you see that the range of services ranged from 831 to about 693 or about 700 clients, with probably an average about 750 or so throughout the period. That's for 9 months. During this 9 months, we had 1,422 unique visitors from October to June, with an average number of visits per day of 32. And over the last 3 months of the study, which was April, May, June, that increased to 39 visits a day. On the right, you'll see the duration that people stay. The average stay was 14 hours, with some just coming in, maybe a quarter, for 6 hours or less, coming in, getting what they need, and leaving. And a few people staying up to 24 hours. Actually, a third staying up to 24 hours, and some a little bit over, as they mostly waited for connection to services the next morning. This 14 hours is similar to other other programs in other counties. LA County's David Murphy Sobering Center, which is in the middle of the downtown area of Los Angeles, has an average of about 12 to 18 hours, and we are right in the smack dab of that. Next slide, please. In terms of who is served, we wanted to look at demographics very closely. We did this both in terms of starting the program and making sure that our staff reflected demographics, but then we also wanted to see who was served. This is in response to the equity lens that the IWG has asked us to assess. Here you can see both sex and gender and age closely mirror our MHSF population as it was defined in your report at the end of 2022. The blue bars are the our program and the pink bars are MHSF. Next slide, please. Most importantly, again, through equity, you can see our racial ethnic attendance very closely approximates the MHSF population. We were particularly interested in the services to Black African American and Hispanic Latino clients. While the 23, for example, for Black African American is less than the 29% represented by MHSF, I'd like you to see the following line on the bottom where 20% declined to answer. So I believe that's probably where some of these discrepancies lie with that, because you don't really see any more. There's no one that's larger than MHSF population. So I believe it's in that 20% that declined to answer. On the language side, we wanted to make sure that we had language competent services. I'm very happy to say that the program manager, Jose Rios, is bilingual by competent, but we also have multiple staff that are bilingual. 2% of the services were provided to Spanish-only clients or visitors. And then our English language guests were 98%. Next slide, please. In terms of where clients came from, most of the clients actually came from the 94110 zip code or the Mission District, and 34% came from the Tenderloin and Soma District. I'm not sure we really have an answer for this. We're happy people came from wherever. Soma Rise actually does lie in the middle of those two circles, so it's not really a surprise that people were either able to walk up from the Mission or down from the Tenderloin Soma. Next slide, please. The average number of visits varied greatly, and I don't think the average is as important as highlighting some of the extremes. 49% came one time or more, or 49% one visit. And we had a small group of clients that came 20 or more visits. As we did the qualitative or quantitative look in a participatory fashion, we looked at that 20 or more visits, and we decided that this is a population we need to do further quality improvement work to figure out what is this 20 or more visits. And there is a belief that this set of, I guess we might loosely call high utilizers, or persons that are visiting frequently, it accounts for about 40% of those that had the 37% of all the visits, which is that over 20 group. We wanted to work with the fire department to see if there was similarity with their understanding of people who might be using services frequently, and whether we can do additional outreach to them. This is a study that we're planning to do. Fire department partners are actually now collecting their list. We're collecting our list now that we have Epic, and then we'll get together and look at this group that's visiting over 20 visits. We think coming back is a positive thing, but we also want to make sure they get linked to service. Next slide, please. All right, so now let's get into the actual study results. So one of the questions that was asked, is Soma Rise safe and welcoming? This is the result of both. The answer here I put in bold from our researchers. Haley Massot from Harder & Company is on the phone if you want to ask them questions after the presentation. Their determination was Soma Rise 24-hour model does cater to guest needs, and it provides an opportunity to rest and time for guests to think about their next steps. This was based again on the qualitative and quantitative data they gathered. Here are some examples of the qualitative data that I think exemplifies this point. From the Soma Rise staff, they said having 24 hours allows guests to sit and process things, figure out what they really want to do, and what is their next step? From clients, you'll hear comments like, the shower was so clean and well attended with supplies, or I felt like the fact that I could rest and recuperate without being disturbed was positive. Next slide, please. Summerrise was also felt to be safe and welcoming environment for guests seeking brief respite. In a participant survey, 85% strongly agreed that the staff made them feel welcome and showed they care and gave them help when needed. And 91% strongly agreed that they would return to Summerrise and would recommend it to others. As one client said, your staff helped me feel safe. Next slide, please. So the next question was, is Summerrise as a person-centered and radical hospitality center? Does it help build staff strong relationships with guests? And the answer was yes, as 91% of respondents said that Summerrise staff treated them with dignity, respect, and kindness during the visit. One of the staff members says, we are a space for the community and we are invested in supporting our guests. It always comes back to the guest. What is it that you want? What is it that you need? As a staff and an organization, that's what we are working on. You know, this is not a random comment among staff. If you go to many of the staff, it's really amazing how much the staff has bought in to the person-centered radical hospitality. I think they've seen the benefits of their work, and I think the work has benefited from their perspective, which again, I believe is we need to be grateful for the leadership of Diana and her team. Next slide, please. So the second question was, does the Summerrise engage people in crisis? We really wanted this to be a safe place where people can experiencing crisis can be indoors. I think when we presented this to you initially, several years back, we gave an example of someone with methamphetamine-induced related crisis, perhaps being disruptive on the street. And we wanted to really impact that, as well as serve as a resource for the street crisis response teams, which for whom we targeted this program. For the most part, the pilot did succeed in serving people in crisis who are using drugs. Here you see the list of drugs that people came in for. And most surprising to me was, while we're mostly hearing throughout all of our treatment facilities and our other low threshold services about fentanyl and the fentanyl overdose rates, that 50% of clients reported recent use of methamphetamine was very significant to me. I felt it met the goal of the methamphetamine task force and sort of a proof of concept. But in addition, it's one of the proven services now that we should think about for methamphetamine use, in addition to contingency management, which we're rolling out through the city. So for me, this was personally very significant. I think it should be something to further look at. And as a safe place for those that are using methamphetamine, I'm just very happy with that result. We also had clients that came in for alcohol intoxication. Alcohol intoxication requires a little bit of higher supervision than the program provided. So we worked closely with Alcohol Sobering Center to develop close linkages, and many of these clients would be safely triaged to the Alcohol Sobering Center to receive alcohol sobering services. From the fire department, it says key partner says, but it was the fire department, I'll tell you that. Summerrise is our #1 destination when SCRT, Street Crisis Response Team, responds to 911 calls. So we're very happy to be partnering with them and the Street Crisis Response Team. Next slide, please. So just to give you a guest view of the program, whether it serves people in crisis, just want to share these two comments, one from a guest respondent, one from a mother. The guest says, I still have September 10th as my sobriety date, the day I came here. Thank you. And the mother of a Summarize guest said, Summarize is helping my son become a person again. I can sleep better at night and feel more hopeful about the possibility of recovery. Summarize is a lifeline for so many who have been suffering for so long. I can't tell you, this was just a heartening letter. Next slide, please. So let's get to the third question, which was very importantly, were guests linked to services? And the conclusion of the Summarize evaluation team was Summarize is referring its class to resources, and the pilot has good communication and strong relationships with other providers. On the right, you see the resource linkages that were provided for guests in the month of April, May, and June. We only have 3 months of data because we were still tampering or tinkering with Epic at this time. And even subsequent to this, we have modified our Epic fields to try to better capture the resource linkage data. But during this month, these 3 months, 22, 28, and 21 persons were linked to treatment. Now, I want to clarify, linkage means that they were referred. I feel very confident that the detox and treatment referrals were actual linkages because most of these were to HealthBright 360. They were walked over to the withdrawal management program just 3 blocks away at HealthBright 360. So I'm very confident about that. Also pretty confident about the medical referrals, which actually has subsequently increased. These are primarily to Maria X. Martinez Primary Care Clinic. The rest of them were, I have the data as referrals, and I can't give you real specifics on did they make it or not. We did have close linkage with initially with the Office of Coordinated Care. When they expanded and had to move some staff around at Office of Coordinated Care with the changeover in street crisis and the onboarding of the BEST team, we are still working on a best way to link with the clients to their ongoing care management. And it will be one of the quality areas that we continue to look at. And in fact, the linkage area is really our next project year over year, is how to improve this, how to make sure that clients not only get referred, but get to the site. And some of the sites we're wanting to connect with, and we've developed really as first phase relationships with all these programs: Withdrawal Management, HealthBright 360, Maria X Health Center, Door Urgent Care, the Best Neighborhoods team, who we have a good connection with. Now we got to connect them after visit. HSH Coordinated Entry, Gubbio Project for housing, 6th Street Harm Reduction for supplies, and many more. We have developed lots of first-person names with the agency directors of all these programs and can make referrals quite easily. Next slide. So we're almost done here. Yeah.
Oh, okay. So,
Yeah.
so Diana's after this slide.
Yes, this is Diana.
Diana's. So can we stop that for questions for you before we move on to Diana?
Sure.
Does anybody have any questions for Dr. Pading? Because Diana Castillo will start at this
Yeah.
slide.
So yeah, I was looking at your facility, and I heard you speak on your referral system or your linkage system. I think that's good. And you have any focus groups, or like NA does the focus group sessions at different areas. So I was wondering if your facility has that. It looks like it can hold something like that. And then also for your workers, or just even for your program, you can download the NA app and add NA to your referral system as well. And then I think that's pretty much it. I mean, I like it that you have incorporated linkage you know, to be able to direct your clients to other services that can help them in their treatment. And I think I think that's definitely needed in helping your clients or impacting people.
Thank you, Member Patterson.
So I'm gonna go Hallie.
I do want that question answered though about your name.
Oh, I'm so sorry. The question was regarding focus groups. We
Focus
did
group.
focus groups as part of the evaluation, and there were surveys done as part of the pre-rollout. I am not sure whether when you're saying focus groups, are you thinking we would provide support groups on site ongoing or
Yeah,
survey
you know,
groups?
Like if you had like a residual focus group that was like maybe 6 o'clock Wednesdays. Come to this circle, you know, this healing circle or this focus group. You know, because they have a number of them around, and it's just another mental health way of treatment. You know, when you have a facilitator, and then you have people sit in a circle or whatever. You know, everybody has 3 minutes to vent or something, or just discuss. You know, like those kind of focus groups.
We can ask that to Ms. Castillo when she comes on up. I think there's lots of different innovations. This is primarily a sobering program, however, and not a treatment program. But we are now thinking, how can we enhance the program within the current funding that we have, rather than adding new services that take away from other programs or bring in programs. So that is one of the issues we're looking at with regards to linkage. With regards to workers, I'm sorry, there was a question there. I think I missed, I didn't hear correctly.
No, I mean, well, I just mainly suggested utilizing the NA app or incorporating that to your referral system for people who may want to go to other spaces and places. You know,
Oh,
for NA
I'm not familiar with that, but maybe I can get a reference from you about the MA app and we can look at that.
NA. No,
Oh, NA. Oh, NA app. Got it. Got it. Okay. All right. Oh, that's an easy one. Okay, I'll ask. These are good ideas.
Okay, I'm just gonna say the order, so I'm gonna go Hallie, Steve. This is just how I saw them, Hallie, Steve, member other Steve. I can't remember your last name, and then Amy, and then I'll go last, but we can't see Sarah, so I don't know if she has a hand up.
If you raise your hand, it
I
moves.
do, but
Yes, yeah.
I do, but I
Okay,
might
so then
withdraw if
we'll
we take
go-
too much time.
Why don't we do the folks online? So Steve and then Sarah, just so that we don't neglect you all.
Oh,
Steve,
cool.
Steve,
Okay, I'll do it quickly because could we just go back to the previous slide on the linkages for a second? I just have a question.
Sorry, and
okay,
then I
great.
switched the order last minute.
Thank you. Dr. Pading, what's reflected in here of people who didn't want to go anywhere? What is the percentage of guests represented by these hard numbers of linkages that happened? Or is this showing, because that's the other area, somebody who may drop in, be there a couple hours and leave, which may be not a problem. And maybe when they come back, they make more of a connection. But what's the percentage of people who didn't accept or have any other linkage that they wanted? They just wanted to come in, hang out, and get out the door.
I don't have the exact percentage. It is the majority of visitors that come in, and many just leave without checking out. Many do check out and say, I'd like to come back again. This is a smaller minority, and it's an area of improvement. So the next steps after we learned with this is we're working with the staff how to give scripts around linkages. Is it better to grab people and when they come on in? Is it better to grab them when they're going out and they decided they already don't want a service? Is it better to do it when they're just waking up or just before they go to sleep so they can think on it? So I think learning how to make a referral and a linkage to somebody that's coming in primarily for respite and sobering is really a skill and an area of learning that we've decided that, you know, I mean, now that we have Epic tools, we can begin to understand what's worked and what didn't. Getting Epic and to the level of Epic and CalAIM certified took a lot of management time. It took at least 9 months to get Epic up and running with weekly meetings and 6 months of biweekly meetings with CalAIM. So you're seeing here on this data, sort of the last part. We got certified for CalAIM in May, and then you got 1 month of June. And so now we have June, July, August, which is unfortunately not on our data set, but the staff is beginning to talk about what is a linkage, what is a referral, how to make these hot, and how to best capture that number who don't really want to come in. It may be just giving them information and letting them know, because a lot of people coming in once or twice. It takes several times, I think, for people to learn the services and then learn to make the next step connections.
No, I think that's right. I mean, certainly, you know, this kind of service, which is so low threshold, I would expect that the percent of people who are just checking it out and be very cautious and self-protective about what happens next. So right now you say a majority of the people, of the guests, aren't in this linkage yet, but that's a goal of Soma Rise, to see how to make those connections without, you know, turning it into a program where radical hospitality suffers because they feel like they're getting met by a salesperson instead of just a place to go rest and relax. So
I'm glad you mentioned that. That actually is the balance. We've been thinking, well, okay, can we even do their Epic intake? Can we even do a health screen? How much are people willing to tolerate when they're coming in and all they want to do is go to sleep because they've been up for 3 nights? So that's been the talent of and I get to tell you that on the positive side, 100%, nearly 100% of people are getting health screened by our EMT. So we're passing the first mark of making sure that people are at least safe. Now at the back end, how do we get them to the next step? And there's been no overdose deaths in the facility. There has been some overdose. I'll let Diana maybe speak to that, of people that maybe used or ingested before they came in. And there's been no significant crisis during the services, or, you know, assaults, overdoses, you know, traumas, breakage of furnitures. But we are, then the last step is, well, when you leave at the door, again, how do we make sure we get those results that we really want and serve that purpose of low threshold linkage?
Thank you.
Yeah. Perhaps Sarah, or
Yeah, this is maybe for both of you, and I'm not sure if either of you were in the room earlier, but Dr. Cummins alluded to basically the neighborhood discomfort when the center first opened. And so I was just curious, when we, you know, are evaluating, and especially if we, you know, determine, hey, this is a great program and we want to be able to expand it to other neighborhoods, or then I think it's really important to note, you know, have we moved the needle on that? Are the neighbors more accepting now, or at least has sort of that died down? Are there examples of even now, you know, having supportive neighbors? Maybe I just kind of wanted a status check on that. And again, it might be more Diana, I'm not sure, but thanks.
Thank you very much for bringing up that. Launching Soma Rise was not without some controversy in the neighborhood. There was concern that more people would be using drugs and coming to the neighborhood and camping out front. We made several conciliations or adjustments to the program to address the concerns in the neighborhood. We offered transportation away from the program so that people would not be lingering after leaving in the front. We made sure that the front of the program has active management, that the staff is welcoming people in and bringing them in and offering them service so they're not lingering on the street in front of Soma Rise. We also did outreach to make sure that people that were in the neighborhood knew about the program and could be brought into the program if they wanted to be brought in. And lastly, we actually worked with neighbors. Some neighbors were very helpful and came to us and said, you know, I really like the idea that you're here, but I don't know how to talk to people. Sometimes it's a little scary. Sometimes I don't know what to say. So we did trainings with some apartment members that live behind the building, teaching them how to speak and refer to people. And we worked with some particularly vocal members of the community. There's Alex of the Sandwich Board, who found us to be a very good resource for people on his side of the Soma district, which was like 2 blocks over, and he'd walk people around. And we continue to work with neighborhood advocates to be a source of referral. We've not received since March of this year, February or so, any concerns from the initial neighborhood group. There are always stories of somebody that can't get in after 4 o'clock. About 4 o'clock, the program fills up, and 28 of 30 nights out of a month, the whole facility is full through the night. To accommodate that so that we have access to the street crisis response team, we have about 3 to 5 pull down cots that we can pull down. We save just for street crisis. So street crisis says we pick up somebody at 2 in the morning, there's no place to go. Well, Soma Rise is the place for them to go because we have extra cots reserved. So currently we have limited at 20, but we reserve beds specifically for Soma Rise. And most nights it is filling up. And we have had complaints that after 5, sometimes it's hard to get in. Does that help out, Sarah? We have to
Very
actively
much.
manage to make
Very
sure
much.
that,
Thank you.
yeah.
Yeah.
Okay, Hallie.
Okay, yeah, thanks, Dr. Payne, for the overview of the report. I look forward to reading it. I had a question. I thought one of the goals articulated by the meth task force in proposing Soma Rise was to reduce the huge number of emergency department, including PES visits that were due to meth-induced psychosis and other dangerous behaviors associated with stimulant use. Have we thought about having one of our goals and then an outcome measure that we would look at would be reduced ED and PES visits associated with acute stimulant intoxication?
First of all, can I make 2 side comments, Hallie? The first is I really want to thank you for everything. I haven't gotten to see you since you announced, and you're leaving is the saddest thing in my day or my month, and I'm sure that many of us here in this committee.
I've loved working with you and working with you to get Soma Rise launched was incredibly satisfying. Your leadership has been amazing, so thank you.
I think the members know there's inside game and outside game. And while the IWG is part of our oversight, part of getting our programs through the department has been Dr. Hammer and Dr. Gonzalez and Dr. Cunnins, and just really giving the support to bring the resources to bear. So I want to thank you. I also want to talk, just as a side comment, go back a little bit to Sarah. We did a 311 survey of encampments and concerns around human, I don't know what the word is, human bioproducts on the street. We didn't see any rise before, during, or after Soma Rise. So just in terms of another measure of impact, we went to 311 data. We decided 911 data for assaults and other things were both too rare as well as not necessarily indication of drug use. So we did not include that. Regarding your question, Hallie, there are multiple factors which we're working together to reduce the ED use. So when we talked with the metrics team, we weren't clear we would be able to parse out what specifically, what portion of this was related to Soma Rise. So we did not answer the question in the way that you're framing it. However, if Haley is on, Haley, didn't we have data, which I didn't see in our final slide set, that only 1% of persons at Summarized were re-triaged back to the emergency room? So we didn't send a lot of bounce backs up to the ED. And we have to think that street crisis referrals, every one of those two or three that came in a night would have been an ED referral. So that's the way I would probably get at that data. So Haley, do you have the number on the top of your
Yeah.
deck?
Hi, I can just confirm that it was less than 1% of visits resulted in the guests being taken to the emergency department. So that's the stat that we have on that.
And from what I understand, the sobering literature, this is probably, I heard this more anecdotally, that a good measure for sobering is that less than 3% of your visits get re-triaged back to the emergency room. So we're at 1%. So I believe that's a very good rate, and is, I don't know if it's better, but it's on the order of scale that our alcohol sobering is achieving as well. Does that help out, Holly?
It does help. I think there are a few different questions we could ask. Would be really interesting to look at the data around whether Summarise actually for individuals reduces their likelihood to have to go to the emergency room, including PES. And then also whether it's made a measurable impact on PES, because back when the MEC task force was meeting, there was such huge concern about PES being inaccessible or at capacity all the time because of people there for stimulant associated emergencies. So
Let me ask if this gets at what you might, one of the studies that we're thinking about, but I can't get Maddie attention yet. Maddie is our internal EPIC data. I don't know what they do. They find data. There are data resource people. So we're working, I want to work with whole person integrated care. Whole person care wants to look at what's the impact of a visit to whole person care. And so I'm looking to join them, and that we take, so that we look at what's the impact of a Summarise visit, and we compare the resource utilization, and the types of visits, the 3-month or 6-month before Summarise. And I arbitrarily picked, if you looked at the frequency, I'm thinking 6 or more visits should be a good dose of Summarise. Did those that visit 6 or more visits have less or more appropriate visits following 3 to 6 months than they did the previous 3 to 6 months? So did they come to the ER less? Did they go to an outpatient clinic more? That would be a good result for me. And this is sort of, I think, a pre-post format that whole person care is thinking about is what we want to hook up with. But again, when we have to wait to an EPIC build, and we're just sort of shadowing whole person care as they're developing this. Does that get at the question that you're thinking about?
Yeah, that definitely gets at it. And I would wonder, and we can bring this up at one of our meetings with DSFG Psychiatry, is whether it's having any measurable positive impact on PES.
Yeah.
I had a
So you're going to be around to
question.
ask that question, right?
Yeah. I'm going to extend my my retirement date. That's that question.
Okay. Anyway, pre-post, that's the way I think that I've been able to figure out would be the best question that we're to answer whether we had impact.
I have a quick question. There's a lot of discussion about what the right care model is for a drug sobering center, which interesting to me is really different from an alcohol sobering center. Have you found with your work with HealthRight that any tweaking of the care model has had to happen?
I'm going to turn this over to Diana, because this really represents the process. This has been a whole learning process, and it was really great to bring Harder and Company online because they really started out, okay, here's the data. What can you tell us from the data? Well, a bunch of people are coming 20 or more times. Why? What are we going to do? What do we need to do to get down to this level? So, and then the same thing with quality. Some people were saying, you know, the staff, for example, was saying, we want more case management. We want to be taught case management. And so we talked about this as a leadership group, and we decided that case management is not really appropriate in a sobering center, that we should better link up with the best services to do that case management in a more coordinated way. Because otherwise, if therapists or if staff were tied up with a caseload, that's not really a sobering model. So those are some of the questions as we've sorted through the pilot that have come on up, that there's been learnings during the evaluation that were very beneficial. We decided, though, that staff can do a lot, and we're going to be holding some more focus groups about what kind of things staff would like to do that's short of case management and what kind of training that they would like. So that's how the model is growing, kind of more organically rather than any real, you know, we're just twisting and turning as clients need. Going to the Gemba, that's what I learned.
Yeah,
Yes.
thanks, David.
Okay. So if I may, Chair, turn it over to Diana because she'll speak to the
There's still more
quality.
questions. I think there's still more questions. So we
Oh.
have Steve and Amy and myself.
Oh,
So
okay.
Steve,
I want to make sure I,
Also-
you know, honor your time too.
I think I'll wait.
Yeah.
until we have the CQI presentation.
Amy.
Yeah, thank you, Dr. Painting, for all that information. And I was one of the people that came to visit the sobering center. It is a very nice place. It's great. And I think, I feel that your sobering center, the services is so critical to really actually be the pivotal kind of place to just kind of have real engagement and transition to treatment. And I think it's kind of saying what Member Patterson was saying about the focus group. When I was there, I was telling people, I said, wow, wouldn't it be great if staff could just kind of start engaging and then start having that linkage process. And I mean, it's great that I understand the whole sobering centers, the purpose is to have them come in, kind of, you know, sober up and then move on. But at the same time, it's such a critical location of a point where that's where we're going to be able to link people to just kind of have services. And I know it's not what the sobering centers do, but I'm just wondering how you were talking about and related to Dr. Hammer about the care model and, you know, linking to what you guys are trying to do is somehow this kind of swerve something in so that the repeated people, and we were talking about that a little bit too when we were there, is that, you know, people could go out, come back after 2 hours, and then they consider another visit. So just wondering, you know, if we can even lessen that number, right, for that visit. And that one visit, is that considered, that 49% for the one visit, are those the one also the 2 hours and then come back, you know? So yeah, I really like to see, it's such a critical place that I think can do a little bit more to help the people just kind of be in treatment and using the sobering center, not as a repeated to just drop in and sober, although I know that's the point, but. Thank you.
Thank you very much. I think that is our next direction, is to begin looking where to go. And this is very good feedback. The issue of offering services, one of the complications we get is the more times people come in, which we want, but it also keeps somebody that is new from coming in. So it's kind of balancing the front door and people that are there and how long they stay and people that go. So when people get what they need, which is to resolve the crisis, they're kind of ready. So if we can offer services within that window, so they're not bumping somebody as a, you know, who needs a space, who is in crisis, that's the delicate dance that we have to do. But your points are well taken, and finding that balance is, I think, something we should look at more.
Thank you.
Hi, this is Andrea. So a few things. I think just going back to the systems impact issue. I think as I understand, the mental health SF ordinance, what it's seeking to do is improve systems. So I think while, yes, looking at individual utilizers of Summarize longitudinally is important, I just go back to that we do, the onus of it is still, not the onus, I mean, the critical part of why Summarize was created was to resolve systems issues that are impacting the ED and PES. And so, and I don't think we should wait until some meeting with, you know, with leadership at SFGH Psychiatry. I think Dr. Leary and Kathy Ballou are very accessible folks that we can reach out to get data on the impact of Summarize, if any, to PS population of utilization. So, I mean, I hope that we can get that information soon, that data soon, if there has been an impact. And then the other thing, I guess I'm just very confused about, and going back to the slide on page 36 about referrals and linkages. So I understand Summarize is on Epic. But is Health Right? Is Health Right on Epic?
No.
No, right? They're still on Avatar, right?
They're on Welligent, but they can view some limited data through CareLink. So they're able to share some information. Mostly it's a telephone call because it's partly the same staff. It's easy to walk people over from Summarize to Health Right Intake Department.
So I'm just wondering, so they don't open up if someone goes into Detox, they open up an episode, right? So we should be able to get concrete data of actual linkage, right, to Detox.
Yes.
So I'm just wondering, so is there any intention to get, I mean, because I feel like there's a conflation here in this data of referrals and linkages. And I think that it's a huge leap. I mean, in our experience in ICN, so that's why I'm a little bit, I don't think this is valid. Because in my experience of many, many years of working with this population, referral to linkage is a huge leap. And so, I mean, despite walking people over, I mean, we walk people over we take people to places all the time, and that doesn't translate to a linkage. It usually takes several or even years for things to actually translate to a linkage. And so I think that there's definite for Detox, we could get actual referral data, it seems. And so I'm wondering if there's an intention to actually get, the referral, you have the referral data, but we should be able to get linkage data because they have to document at Health Right if they actually entered into Detox. So is there a way to get that data?
I think I'm not adequately sharing when we did the study, we're still at a very early stage of the program. We had just implemented, I think, Avatar. This might be the first data we were getting out of Epic. Was this data from Epic, Hallie, or was this still drawing by hand counts as we went through the data?
Latter, this was actually data that was provided to us it's captured in Excel. So at the stage that we were looking at this data, it wasn't being captured in Epic yet.
Right, so we're still building Epic as you're seeing the evaluation, and we don't have a final product yet. And then when we all move to Epic later on, I think we'll be able to get better studies of the linkages from Epic to other behavioral health services, let alone Epic Summarize to other medical services. So this is where it's kind of like we're in process of trying to get to the point that you're wanting. But at the conclusion of this report, we've just finalized Epic. We're just pulling some data from Epic, still some by hand, and you're seeing a report that's in transition as we continue to build the services while we're running. Again, we did CalAIM, we did Epic, we trained staff, we did all the protocols, worked on these relationships within our clinic, and all within kind of like a 9-month period, because the first 3 months we still didn't have all our supplies and just had finished construction.
If I could jump in here and say, like,
So I just want to, it's not an excuse, it's just, but yes, if we very much agree where we want to go with that.
It's 11:10, and we have Diana Castillo here, who is, part of Health Right 360, and she has a client load. I'm sure that she's also thinking about going back to serve, as well as Haley also has other responsibilities that she's going back to. So perhaps we can pause on the questions. Diana, we can give you an opportunity to share some of your experiences, and then I think we probably need to do final questions and close.
Thank you, Dr. Pating. And I don't in any way, I think that Summarize is a great resource. I just hope that we can get the data that, to demonstrate.
I understand that you're wanting that, and Ms. Kirby has shared the eventual goal that we provide, more data on our services. So we'll be looking to provide that to you as soon as I can get more of our evaluation time from our Department Maddie team.
Diana, can we turn to you?
Yes, good afternoon, everyone, or morning still, sorry. And I can touch a little bit on some of the questions after I finish the presentation as well, because I do have some information to add to that. But some of the challenges, again, that we've identified and how we're addressing some of those things. Again, the linkage, as we know, is a very important piece of how we get folks out of returning and continuing to be in a state of crisis. And so we really try to streamline those referrals and improve just the conversation and coordination with the street crisis team for drop-off. So we have a great communication. Folks usually call us ahead, will let us know, hey, we're bringing so-and-so. This is what's going on. Here are the vitals. And we are able to seamlessly bring in the folks that SCRT is bringing. In the same way, we have also been able to make connections with other folks and other providers. The Alcohol Sobering Center is one of our biggest partners in the sense of there are a lot of people who don't really know, they just hear a sobering center. And so sometimes folks are walked or folks are brought on to Summarize to be seen there. However, we know that responsibly alcohol sobering should be done in a different place. So we usually do those connections there. As David mentioned, our EMTs are a key piece of this whole operation, making sure that folks are medically stable and safe before they are able to rest. And I think that this kind of gets at the EMS portion and question of things. If folks are able, if it's something that needs attention right away, but it's not a full-on emergency, we are able to transport folks to Door Urgent Care or Maria X, and we make those connections and we tell folks, hey, we're going to take you over here and then you can come back after this is taken care of. We also try to ask questions regarding primary care and any information that we can get to really have a more robust information and regarding where the client is at the time that they're arriving to our facility. For our admission process, as I mentioned, there are ways that we can make that a little bit more seamless for clients. If there are partners who are referring clients to us, we really have tried to have direct contact and connection with them to be able to clarify the admission criteria and just have the open lines of communication in order to make the process more seamless so that folks are not waiting outside. People usually try to call to ask if we have any beds available so that folks are not just standing outside and then being turned away. And then really the process of really hearing and listening to people and what they want. I know that we are so used to probably, and we try not to in this field, to impose services on people and know what's better for them, and really try to listen to what folks want and try to intervene and also give our professional opinion on things as well. Defining the core objectives and outcomes really has been a process of again, really listening and talking to the guests, and really knowing what is it that they're intending to do, what are their needs, what are their more immediate needs. And one of the things is, how do we link to services? How do we have the relationships not to only accept folks as referrals, but how to link people seamlessly into other service providers as well, with the coordinator, the Office of Coordinated Care, the BEST team, Health Right 360, and many of the other partners. And so the staff, myself, and the program manager, we have done, I think, a great job of making those connections and really connecting personally with the directors and the programs to make sure that they know who to call, who to contact, and also who we can contact when we have folks who are ready to enter into treatment. Next slide, please. This is a portion that, again, David mentioned, the implementation of Epic, and really trying to get a robust system for us to continue collecting data and being able to evaluate and really become more data driven. Has been a process of moving from taking spreadsheets and having the information from that into being a little bit more streamlined. And we are seeing, with the implementation of CalAIM, really seeing a better way. And I think this gets at the question that was being asked as far as linkages. We met with the CalAIM teams already. People have come from the payer side to visit Summarize, and they've been really interested to really see the connection of folks who go to Summarize. They get that claim, and then they also get the following day they may get a claim for another provider, right? Like whether it's detox or if it's the emergency room, and they can see why this person was not able to come into sobering and was sent to emergency room instead. So they have already started making those connections. So I'm really excited to see how we can start really seeing and and being able to evaluate that even more, to really get at the questions that you are asking now. And then this portion of the high utilizers, I know we tend to look at high utilizers as a negative connotation, but really for us, having a sense of, it is good for us to have people come back. As many of you know, in this field, treatment doesn't happen the first time, and sometimes it takes a little bit of time for folks to trust and to get to know people and to really be able to enter into care. So we are the place where people are coming in and trusting that when we are making a referral or when we're sending people somewhere, there is a way and there is a path for them to enter the system. And so I think as we look at the definition of high utilizers, we definitely are conscious that these are folks who continue to come back to Summarize and may not be entering treatment right away. But at the same time, that gives us the opportunity to continuing just building that trust, and also knowing that at some point they will make that leap into connecting to other resources and services. Next slide. And I think, yeah, that's it. Thank you.
Before we go to questions, I'm wondering if we could do a time check and decide collectively if we want to spend time on questions. Or Jen, I know you had thoughts about the time now for questions versus other agenda items.
I think we have to pause for questions related to Summarize before we talk about the other.
Okay.
Yeah.
Are there any questions?
Yeah.
Okay. Anybody on the Zoom that has questions, or if not, is it just Member Patterson and Member Steve Lipton?
That's what, oh, good.
Okay,
You can
member
do member- You
Patterson.
could do member guy next to me.
And like those, one of the Steves, I can't remember which. Member Patterson and member Lipton,
Eastfields.
and he's too, yeah.
Steve.
I was. Patterson.
You just call one of them Step. But, so you mentioned about, determining or, basically, trying to figure out clients' needs as far as, the referral process. And, I just wonder if you have a system of differentiating clients and the different levels that clients are on, like they have somebody that's really just there to sleep. And then you might have somebody that may be a little more advanced. I could say from working in the shelters, there are people that, I know a sober center is not a shelter, but, there are people that work every day. And there are people that had, more strenuous mental health issues. But that system of like differentiating wasn't always there. So, things kind of went through the motions that way. So I was just wondering if you have a means by the way of examining the different levels that your clients are on.
Yeah, so as mentioned, this is a very low threshold entry point for folks. And so really, now a little bit more with the introduction of CalAIM, but most folks that are coming in either intoxicated or really in the middle of a crisis. So for us, our initial point of entry is just to give the client a safe space, get through the medical exam, give them some food, make sure that they have what they need, that their basic necessities are met, and then we can start having a little bit more of the conversation throughout their stay, right? Some folks just really need to get through and just get to bed and rest. So it really depends on the state of the person that is coming in. And sometimes, folks may get up and go to the bathroom or say, hey, like, I'm hungry again. Can I have some food? That's when our peer supports or the supervisors or any of our staff will engage and really start having more of those conversations. Hey, how are you feeling? Do you have a plan of where you're going to go next after today? Right. So that's when the conversation happens a little bit more, but it's more motivational interviewing type of and just really conversational. And based on that, we start kind of developing with the client, hey, here are some options for you. If you're ready, we have this, these services available. So that's the level of triaging. But in the beginning, it's really about just giving the client what they need. So food, shower, a bed, and making sure that they feel safe, because many of them do come with wounds. Many of them come with, sometimes just like cuts and abrasions from being out in the elements.
And because I'm not there, I'm asking for kind of a visual of how many, like we're at 11:22. A number of members need to leave at noon. And so I think we probably need to think about if there's some burning questions, let's ask them. But if they're not burning questions, then they can wait. Let's move on. So are there burning questions that we need to make sure that we address?
Mr. Lipton has a question.
I deferred my question before. And I think I'm going to succinctly just suggest that the core of what I look at here is the number of repeat visits and the number of guests linked to services. And I think there were some good suggestions in terms of the CQI presentation, but I think we ought to figure out what would be a reasonable, and also remember Hammer's comment about the impact on emergency departments, that we should figure out a time frame in which we have a follow-up report on both of these issues. Whether it should be 3 months, 6 months, or whatever, but we schedule some type of follow-up to see kind of where we are on both of those issues. That's it. I don't think I need an answer, but just say it should be on the agenda. And
Yeah, we
Valerie,
can-
very,
we can put
very
that-
quickly making a note of that.
Yeah, we'll put that on the.
All right, we can move on.
Yeah, we'll put the 6-month check-in as a possibility and kind of, and as we do our planning, as we now do at the end of each meeting, we can work that in and see. Diana and David and Haley, thank you so much for joining us and for all of your important work. Really appreciate it.
I just want to thank the team. They've been really, really great. HealthRight and Diana, your team has been just delightful partners to work with. And I want to thank you for everyone's commitment along the way.
Thank you. It's been great.
Thank you.
And so, can we come back to the agenda? So it looks like, we're
We do
trying.
public comments, then we wrap. this
Oh,
up.
shoot, yeah, let's do public
Yes.
comment.
So we're going to quickly do public comment for discussion item 3, which is the Summer Rise program. There is no member of the public joining us in person. So if you would like to publicly comment, please raise your virtual hand. If you're calling in, please press pound, then pound again, and then *3 to line up to speak. And then wait till the system indicates you have been unmuted. And I'm going to refresh the attendee list now to see if anybody is raising their hand to make a public comment. I do not see any raised hands. Kaylee, can you confirm whether or not you see any raised hands?
Nope, I don't see any either.
Okay. And I think we can close public comment for the Soma Rise discussion item 3.
Great, so it looks like we're gonna try and cut some, reschedule something from the agenda to next month, right? The community engagement update and discussion. So we're supposed to have a 5-minute break now, and then then we come back and we'll hear about the annual implementation report. And then the item.
Chair Salinas. Maybe one of the things that we could do is we're going to cut community engagement, as you said. I don't think we're going to be able to get through everything. And so perhaps we can focus on the implementation report first, the OCHO, whatever that is, that update, and then planning. We did set for a 5-minute break. I just want to ask the group, is 5 minutes? We're gonna close at noon. So do you want to go ahead and take a 5-minute break now, or do you want to power through?
This is only 5 minutes unless. Yeah.
You're okay? We can power through, because I think that people have been taking their bio breaks as needed.
Okay.
And if I may, Jen, one other piece we were discussing over a text that we might suggest to honor the request to end at noon is we could consider postponing elections for a new chair, vice chair until the January meeting. But the same process would be just somebody would serve as acting chair in that meeting and we can conduct the election then. But we really do want to get you guys out on time today at noon as intended. So is that, I see nods. Are we in agreement? Okay.
So then can I just confirm what we're doing? So what I heard is we're going to do discussion item 4 next, which is the implementation report. That should be quick. And then we're going to do discussion item 5, which is also a quick one on Our City, Our Home. We'll skip discussion item 6, which is community engagement. We will also skip the governance and membership update, which is the election. And Dr. Coonan's already gave the membership updates. We're skipping discussion item 7 as far as I'm tracking. And then we would go next to discussion item 8, which is meeting planning. Is that correct?
I think 8 is adjourned. I mean, on this,
Yeah, discussion item 8 is the meeting plans that would slide 68.
so we're not gonna do.
Let's do the implementation report. I think
Yeah.
that is a very important update.
Right,
and-
exactly. That's
and-
discussion item 4, which is what we will start with right now. That's, yes.
Okay, great.
So that's page
We're
41.
going 4 and then we're skipping to, apparently there's an 8 in here, so it's different.
We'll do
4,
4 and then 5.
okay, 4 then 5. All right, we are moving on to discussion item 4, discussion about the DPH implementation project. Diana.
That's passing. Actually, it was going to be Kelly, but I think it's you, Valerie.
It is me. All right. I am the voice of the department. So, as you know, the MHSF legislation, I'm using my theater voice. Don't worry, I don't know. I'll let you cut. The department will produce an implementation report every year on MHSF. This year, we're trying to make it a little bit more concise. So we intend to highlight progress toward implementation and goals for 2024. The report is supposed to be submitted to the board, the mayor's office, and to the IWG to review and assess. We're currently working with our domain leads on, setting their goals, reviewing their progress, and drafting their sections. And then there's going to be a rounds of executive review. What we would like to do is get a copy to the IWG to review the week of your next meeting in January. Allow review and comment that week. I don't know that there will be a lot of if somebody has feedback that would demand a substantive rewrite of the report, we probably wouldn't do that, but I think we would like to get your feedback on, the direction the report is going in, and also get some ideas from that about what agenda items that might raise in your minds for the what we bring to IWG meetings going forward. And so before you get before you get to the next meeting, probably the Monday before, we will send the report to you, and also have either Kelly or me or Dr. Cunnins talk you through during the meeting what is in the report, where
You're talking about providing it the day before the meeting.
and then talking through it in the meeting, and then reviewing that with you.
And would the expectation be that people are supposed to read it?
No, just getting it to you and then talking you through it in the meeting. So, it would be, but we would not encourage you to read it the day before meeting, just to review it and offer feedback over the course of that. So, that would be, yeah. We are aiming for a shorter report, but recognizing that would be a lot. So the last week of January is.
You don't think it's going to be available before?
I don't think, given the writing and review process, I don't think it's going to be available. But that is what I'm able to offer. So.
Okay, so there's not much to say about it, right? So we'll get it for that meeting. There will be some brief discussion, but the expectation is that then following the meeting, we will send comments. Then will it come back to February?
I think we can.
But it'll be done.
It'll be done, but I think it's, I think depending on what your feedback is, there might be other agenda items we bring to the meeting. I want to hear more about this. I think we need more here, et cetera. So I think it'll help guide us about what else we want to talk about in subsequent meetings.
But it'll have already been submitted to the BOS.
It will.
Any comments? I think it's less than optimal, but I don't know that it's suboptimal, but I guess there's not.
There's not a clear process, I will say, in the ordinance for what review and assess that duty looks like. And it's, I think we're working to improve it. I know last year it was provided after the fact. We're working to move it back.
Okay, so we're moving in the right direction. Okay. Anything else on this? Anybody have questions? People at home?
You have to have public comment on this.
Yeah. So then
That's another 5 minutes.
can we move to public comment? Are we ready to move to public comment? Okey doke.
Okay, so public comment for discussion item 4, which is the DPH implementation report. There are no members of the public in person. So if you are participating online and would like to comment, please raise your hand and Kaylee will call on you to unmute. If you are dialing in through a phone, please press pound and then pound one more time and then *3 to line up to speak. And then a system prompt will indicate that you have raised your hand and we will unmute you. And I'm now going to refresh the list of public member attendees.
To left.
Somebody does have their hand raised. Kaylee, can you please unmute user 4?
Yes, user 4, you've been unmuted.
Oh, thank you so much. My name is Trevon Hunter. I was trying to pound for the previous agenda, but also part of it is around the system. In your report, when people are reporting out, if they could share some of the challenges in their storytelling as well, because I know that it was questions was asked about the challenges and there wasn't a response, but in the presentation, it was definitely information about the successes. So it would be great to have both available in the presentation as well. My other part of that is that there's a crisis around fentanyl, in particular African Americans, and that we keep dismissing that. The first speaker brought it up about the report that's going to come out. We already know the numbers is that over 50% is African Americans that are dying, and that in the man's presentation of the SOMA, he talked about, we know we have fentanyl, but he would like to focus on the fact that they're successful with meth users, and that I think that is a egregious act. I think that's a continued dismissal of African Americans' presence here in San Francisco and how we are treating them. And so I would like us to make sure that linguistically, because, you know, African Americans do have their own language as well that we tend to also dismiss as if we don't have presence in that way. But that too needs to be addressed in a holistic and cultural responsive way. I can go on, but I'm going to stop there. Thank you.
Any other members of the public who would like to provide public comment? Let me refresh. Haley, I do not see any other hands raised. Do you?
I don't see any other hands either.
Thank you. And we can close public comment for the implementation reports. Bring it back to the chair.
We are moving to discussion item 5, a report back from the RCR home meeting by members Hammer and Patterson.
I'll let you start.
Okay. So we attended the RCDR home special meeting last week. It was supposed to be sort of a retreat. It was an extended meeting, but they didn't have quorum. And so they were a little discombobulated. We did meet with them and they had some questions for us. We talked about mental health SF and what's been implemented, what R does. I guess the thing that I would say a little bit during the meeting and then after the meeting, I felt like there was some blurring of the distinction between why the two of us were there representing IWG and me being seen as part of the DPH, and so representing mental health SF. And so there were some questions to me about like exactly the data to show what the proxy investments have resulted in and speak to that. And so I was really trying to speak to really what we as IWG have reviewed and not sort of my internal understanding. But I did encourage them to invite, especially the analytics and evaluation team from Mental Health SF, to share the data, to share the public facing dashboards developing, because I think they're asking valid questions, but it really wasn't questions appropriate for us as IWG members. So I try to just reflect what we have heard from behavioral health services, but not like internal understanding of data that's being worked on. So that was my impression. I do think, I mean, they really, especially Chair Williams, like really wants there to be more collaboration and us working together. I think that's a great idea. I don't know what it'll look like. We didn't really get to that kind of discussion, but I think it's a great idea. So.
Yeah, I would concur. I think, you know, from the board members that were there, they have their own experience. Like Chanel Williams, just she's over Rafiki right now, and she just has a long experience in the city and working, you know, in working capacity. So there's member Walter, you know, he worked for HSH for a long time, and all of the shelter peer monitors how to handle clients and, you know, avoid litigations and problems and things like that, but also how to handle people with care. So I think like they kind of had, you know, a lot of their own viewpoints as well. And they did feel like a need for like, you know, overlap with the committees. So that we can get on the same vision and discuss. I think what's consistent is kind of seeing that mapping out system. Like they had concerns about that, about really, you know, just organizing the system where there's more clarity on directions to go. It was also concerned about, you know, the racial equities as well. The stigma of Black people. How are the services reaching to the different racial demographics equally? That was definitely discussed, and I think a lot of the reasons behind them wanting to, you know, just a clear mapping out system of the system of care that we have is because they themselves have a lot of experience in the game. You know, so I think that's been consistent what we know from messaging in our group. And it's also been consistent, you know, transparent to their group. You know, they echo the same things, you know. So yeah. And yeah, and then, you know, like yeah, some of the questions were you know, out of my bandwidth. or really waiting for me to be, you know, answering, you know. So I just stated what I reviewed, things that we discussed here. They asked about how do we address the issues as far as African Americans being serviced, you know. And I did respond and say it is kind of vanilla, like just basically, you know, we just kind of go over numbers. That doesn't really determine impact, you know. You can dress up numbers anytime, you know, numbers don't lie, but they don't always tell the whole story. So, so you know, I think, you know, there's room, you know, for our groups to meet, just to have that clarity, just to develop that direction. I think me and Amber Hammer were a great compliment to each other. And as I got in it, you know, just kind of figuring out what it was all about. Because I got a long list of notes from like meetings we had. I'm like, yeah, I should have been looking at this. But now, you know, it was I think we represented well as a group, though. Yeah. And they didn't have quorum. They need more members. Yeah.
So they're also looking period for members, or that folks just
I think
show up?
it seemed like I think that they're supposed to have, I want to say 9. There were 4 there. And I think they have some empty seats.
Yeah, yes,
Yeah.
They're running into the same. problem.
Yeah, I think
It was like 4.
I think they have 6, remember they talked about 2 people who didn't make it? So I think they have 6 total. So I think they have some empty seats.
There were like 4 that were there.
Yeah.
Yeah. Something else. It wasn't that many people, but it was more people than we have that was in the public. There was somebody else. I think she might have presented here. I don't know, you know, I'm community organizer outside of this, but I seen her somewhere. Presenting, so. Yeah.
Well, thank you guys for representing us there.
Sure. Pleasure.
Okay, so I guess we're skipping to.
Now we're on public comment for.
Oh, yes, public comment.
Oh, my goodness. Yes, gives you a minute to just like, you know,
And I
meditate.
I have an email out to our city attorney content to clarify the rules around discrete agenda items and public comment, and if there's a method that we can combine some of these sort of short items. Yeah, so.
Deanna, take it away.
So public comment is now open for discussion item 5, which is the report back from Our City, Our Home. There are no members of the public here in person, so if you would like to publicly comment, please raise your hand and Kaylee will call on you. If you're joining by phone, would like to make a public comment, please press pound and then pound again and then *3. And then wait till the system indicates that you have been unmuted. And then you may begin your comments. All comments are limited to 2 minutes, and we will give you a warning when your 2 minutes is being close to over. I'm going to refresh the public attendees list. I do not see any hands raised. Kaylee, can you confirm whether or not you see any hands raised?
No hands.
Then I think we can close public comment and I pass it back to the chair, and we will now go to discussion item 8, which is on slide 58. That's the IWG meeting planning.
We are moving to discussion item 8, discussion to co-plan the agenda for our next few IWG meetings. And Jen.
Yeah, so this is our 3rd month where we've been doing this collective planning for what our meetings are going to be. And as usual, we have some potential January topics that are being queued up that are things that we are tracking. So we would like to test those with you, and then to be able to and see if there's anything else, and also continue to track these topics for future meetings. So we have those over there in the wings. I do think that like we need to be sure that that we check in on this process probably in December when we're doing a little bit of housekeeping. We'll check in on, we will vote in a new chair and vice chair, and we'll do a little bit of housekeeping to make sure that these processes are working for everyone. But the potential January topics are the staffing and wage study, which is a controller's office they would be coming to present. The DPH implementation report, which is what Valerie we discussed today, and what that process is going to be. We thought we definitely need to bring back community engagement because Interethnica is getting ready to go into the field and do some of that community engagement. And so we want to have a touch point with all of you on that. And then the mapping review, and just to be specific, the mapping review relates explicitly and specifically to the maps that are they are actually posted in the agenda online for members of the public. And the IWG, you received these before. These were the system of care presentations and some of the client flow. So mapping review relates to the client flow information that you received. And we'll have Ashley here to give a little bit more detail. So those are the potential January topics that we've talked about. Steve, I see your hand is raised.
Yeah, one thing I think we would like to specifically have addressed by Dr. Cunnins in her report is the impact of the rather devastating budget instructions from the mayor's office regarding particularly years 24, 25, and 25, 26, and how she, at this point, sees it affecting the implementation of the priorities of mental health SF.
Making note of that. Please do.
I wanted to suggest that we move the analytics and evaluation dashboards up as much as possible, if not January, February, because I think it'd be great for this group to see those dashboards. And for us to start being able to track data as we're getting presentations. And then the other comment I was going to make is, since we're trying to limit the time of the meetings, hopefully to no more than 3 hours, and we have a lot of topics, it would be great to give the speaker, the presenters, some parameters about how much time to take.
Thank you.
Yeah, we do our best to prepare folks. And they also don't like, some of this is is not also shortchanging the conversation that you all have with them. So, but definitely heard.
We also started a bit late too, so that was part of the today. So that was part of the other issues. So yeah.
Valerie?
I just wanted to weigh in to emphasize, these are just potential suggested topics. Like, we really during the meeting optimization group, we want to try to make space for you guys to suggest other topics that are of interest to you. Feel free to do so now. Otherwise, also, if you want to email me or Jen, Diana, and Kaylee and me in the next couple weeks too, if there's other things that come to mind. So I'm happy to try to add other items to the agenda or construct the agenda so that there's more space for making sure that it's like what you want to hear and elevating your priorities. So just emphasizing it's an open door. So.
I mean, I think Steve's got his hand up first. Go, Steve.
No, that I just saw, I'm not quite sure what Behavioral Health Commission means in the future meetings. Is that the select committee?
There is a behavioral health commission. It's in other counties, it's the mental health board. So that is our mental health board. There was some interest expressed at a prior meeting of inviting them for a collaborative conversation. I think at the time I said they were going to the board for Board of Supervisors, which they went this week to restructure some of their membership and processes. They were also struggling with quorum. They were struggling with severely struggling with quorum and with getting appropriate membership for their seats. So they need a little time to settle in now that they have been straightened out. It's been straightened out of the board. But I think we want to hear more from them about what would be of interest for that conversation and be able to talk with them and start to.
This is the long-standing mental health board that was originally established in the LPS Act, and this is the citizens appointed by. It's not a commission though, because it doesn't have a status.
They changed their name to commission.
They changed their name to commission. Well, that's
From Mental Health Board to Behavioral Health Commission. It used to be.
Yeah, and I think there was a board resolution that. Oh no,
that's aspirational. They're originally only an advisory board, and then they changed the name. So now, okay, that's great. Then I understand what group that is. It's been around for 40 years. Yeah, thank you.
I do want to add, in the ordinance, it does say we're supposed to report to them.
So there's supposed to be.
It does say that in there.
Oops.
It's like the health commission says the behavioral.
I think
So I just wanted to.
It's the health commission.
it's the health commission, not the behavioral.
It's supposed to be, I think if there's a collaboration language in the ordinance, and so I would welcome.
Yeah.
I would welcome.
I feel like there's some specific language in there about the Behavioral Health Commission as well, but collaborate, maybe that's collaborate, and then we were supposed to report to the Health Commission and collaborate with.
Advise them. I need a diagram sentence with all of those. Yeah. I think Sarah had her hand up.
I just wanted to say that in terms of the potential January topic list, I'm not sure if that was a suggestion that we could do all of them, or it's like a menu, pick and choose, but looking at it, I would say, and even comparing it to the future topics, that I would say those are all really important ones that we should get to as soon as we can, especially because a number of them have been delayed. So I'm in favor of, basically following that as next, the framework for next month's meeting agenda. Just wanted to put that out there.
Next door is clapping. Next door is clapping right when you said that, Sarah. Support for your statement.
Oh, what? There was clapping? Really? I got
Yes,
applause?
from the party next door.
Well, I'm sure the walls are thin and they heard and yeah.
Exactly.
So, thank you. I feel good about that.
I guess this community, we need all of these in addition to the analytics. I think that we should prioritize that. Interethica is needing to go out into the community very soon, right? So, and I guess I did have one question, and the mapping is related in that with the providers. So I think those have to happen right next month for the timeline for them to be able to do their work. So those should definitely be prioritized. I did have a question, because the ordinance says that we're supposed to have these community meetings. And so the community meetings, we don't have to attend in our Interethica. I guess that was the question I was having. Interethica is going to take care of it.
Yeah.
The IWG members are we?
No, I think, yeah,
We were supposed to do it.
the way the ordinance is written, it does appear to sort of assign tasks, to the IWG but I think following the model, has been used, for example, for the staffing and wage study or anything like that, it can be performed by other parties on behalf of the IWG. So in this case, Interethica is performing it on behalf of the IWG. So, yeah.
And that the staffing and wage study, I imagine is going to be take a lot of time. I'd imagine we're all going to have a lot of questions. So just about trying to cram too much into a January meeting.
Henry, one thing to note is like the mapping review, like that could potentially, that is not contingent on what Interethica does. So Interethica is going to be using these maps, communicating with the community about them, getting feedback, and that's going to come back to this body. The mapping review was really an opportunity for you to just kind of talk a little bit about what those maps are that they're taking out to the community, but there's going to be another opportunity later on to do that if you wanted to bump that and provide more space for some of these other conversations.
And I think the feedback regarding constraining the time for presenters would be very important here. So that,
So who's going to decide what's on the agenda?
I think it's a combination of this conversation, taking this feedback, and then also, we can confirm what amount of time each of these parties would think they need. And Sarah, I may lean on you in your last few weeks as acting chair to weigh in on some final decision making, if that's okay.
Good.
Great. Okay.
All right. So are we ready? Do we need public comment again? Yes.
We get to have public comments now for discussion item number 8, which is IWG meeting planning, which is the next slide, please, Kaylee. Thank you. There is still nobody here in person, so if you would like to comment and you're a member of the public, please raise your online hand or press pound and pound again if you are calling in, and then *3. And public comment is limited to 2 minutes for each person. I will refresh the members of the public who are joining us. I do not see any hands raised. Kaylee, can you confirm whether or not you see any hands?
No hands.
I think we can close public comment for meeting planning. Oh, then it's another opportunity for public comment on other matters within the jurisdiction of the committee that are not on the agenda. So any public comment on anything that you have not been able to publicly comment on yet. Same process, so raise your hand online or pound and then *3 if you are calling in. And again, you will be limited to 2 minutes, so I will refresh the list, and so please raise your hand now if you are a member of the public and would like to comment. All right, so let's leave this one open for a couple of seconds because this is the final opportunity for public comments.
This is.
Yeah. Haley, can you confirm whether or not you see any raised hands? I do not see any.
No, I don't see any hands.
Search one more time. Okay, so I think we can close public comment and move to slide number 62, which is housekeeping and Jen.
Not much housekeeping to do. There has been no requests. There are no discussion groups. The meeting procedures are the same as everything will be posted to the working group. I do want to encourage you to look at the reports and resources page of the IWG website because it does have links to all of these reports that we talk about, like the dashboards. And of course, there's always that email for the public to comment. We do monitor that email. We always include as the next slide. We always include this slide because there's lots of stuff going on. There's, our city, our home meetings. There's the Behavioral Health Commission with lots of subcommittees there and the Health Commission itself. So we include those as awareness for you if you would like to go to some of these and see what they're talking about and what the overlap is.
All right. Well, thank you so much, Jen. Thank you, everyone, for this meeting. I hope you all have a wonderful holiday season and that 2024 brings you all much joy and good health. Our next IWG meeting is on Tuesday, January 28th, starting at 9 a.m. at our usual location at 1380 Howard Street.
And the 23rd, sorry, the Tuesday is the 23rd, not the 28th.
Look,
It is a Sunday, so do not come on the 23rd.
Okay, Tuesday, January 23rd, starting at 9 a.m. at our usual location, 1380 Howard Street. Can I have a motion to adjourn the meeting?
I second.
All right, we've got a,
Kristen and Hammer.
all right, this meeting is now adjourned. Go in.
Is that you? Thank you.
I was gonna forget it.
It's like, go in peace.